In this video, we'll discuss about measles. Measles is a highly contagious, serious airborne disease caused by virus that can lead to the severe complications and death as well. So vaccination is a very effective way of preventing measles. Mostly the deaths globally, they occur in the unvaccinated or under-vaccinated children. Talking about the epidemiology, this virus can affect anyone, but it's more common in the children. Humans are the only natural host, and the outbreaks they typically occur in the late winter and early spring. In vaccinated population, the age distribution is shifted towards the adolescence and the adulthood. Let's talk about the recent outbreak as well. Recently, there has been many outbreaks throughout the globe, including United States. Outbreaks they basically occur because of the vaccine hesitancy due to the misinformation about the possible vaccine-related side effects. Similarly, reduced vaccine uptake during and after the COVID-19 pandemic is one of the reasons why we are facing the recent outbreaks. Moreover, lack of awareness about the severe consequences of the measles infection itself is the next cause. Similarly, because of the ease in the global travel, people are getting measles from the different part of the world and bringing it back to their country. So that's also one of the reasons why there are recent outbreaks. So talking about the recent outbreak in the US, recently, as of the February 27, 2025, total of 164 measles cases were reported in the 9 areas. In 2025, there has been 3 outbreaks till now, and out of which 93% of the cases are outbreak associated. So in 2025, there were a total 164 cases in the US. Most of the patients who were affected included the age group of 5 to 19. Most of them were unvaccinated or their vaccination status was unknown. Moreover, only 2% of the people who were vaccinated were affected by the measles. So this also shows that the vaccine is a very important part of the prevention of the measles. So among these infected people, about 20% were hospitalized, and the hospitalization was highest among the patients of younger age. Till now, there has been 1 confirmed death from the measles in the United States. Measles virus is also known as rubeola virus. It belongs to the genus Morbillivirus of the family Paramyxoviridae, and it is an enveloped, non-segmented, single-stranded, negative-sense RNA virus. And its genome encodes for at least 6 structural proteins like matrix protein, fusion protein, hemagglutinin, large protein, RNA-dependent RNA polymerase, phosphoprotein. So among these proteins, this H-glycoprotein is involved in the attachment of the virus to the host cell. And similarly, this F-glycoprotein is involved in the spread of virus from one cell to the another. So the major receptor through which the measles virus enters the human cell is the signaling lymphocyte activation molecule, SLAM. Another protein, Nectin-4, which is located in the epithelial cell, is thought to be the protein which is responsible for causing virus to pass through the airways, which helps in the spread in the aerosols. This picture shows the entry of the virus into the human cell. You can see this SLAM receptors are responsible for the virus entry into the host cell, and after replication in the host cell, this virus is shed into the airways with the help of this Nectin-4 molecules. So talking about the pathophysiology, this measles virus infection starts from the luminal side of the respiratory epithelium. The respiratory epithelium, they contain the many other types of the cells other than the epithelial cells, like other immune system cells like dendritic cells. And these dendritic cells, they carry this virus from the respiratory lumen to the regional lymph nodes. And after infecting the regional lymph nodes, the virus spreads systematically, causing the viremia. Transmission occurs through the respiratory droplets and the small particle aerosols. When infected person breathes, coughs, or sneezes, virus remains active and contagious in the air or infected surface for up to 2 hours. So who is at risk of developing the measles infection? Usually it occurs in the non-immune person. They include non-vaccinated person or vaccinated but who didn't develop the immunity. And it basically occurs in the people of the low socioeconomic status. Incubation period usually is around 10 to 14 days after the exposure to the virus. Infectious period lasts from the 4 days prior to onset of the rash to 4 days after the rash eruption. So clinical manifestations include fever, and the patient will have these 3 C's: cough, coryza, and conjunctivitis. Sometimes patient can present with the Koplik spots. These are the bluish white lesions. slightly raised by 2-3 mm on a reddened base on the oral mucosa at the level of the first molar, as shown in this picture. They occur the day before the onset of the rash, and they usually persist for 2 to 3 days. These are the pathognomic signs of the measles, and they can even occur at the soft palate or the vaginal mucosa. And the rash usually occurs after 7 to 18 days of the exposure, and it usually starts in the face and the upper neck, and it's a maculopapular rash, and it spreads to the hand, feet, and other parts of the body over about 3 days. It lasts for about 5 to 6 days before fading. These pictures also show the rash. They show the rash in the face, similar rash in the body, as well as this shows the rash in the both face and the body. This shows the viral enanthem. So the other clinical manifestations include photophobia from iridocyclitis, pharyngodynia, headache, abdominal pain, and sometimes generalized lymphadenopathy as well. Differential diagnosis for the measles infection is broad. It includes the viral infection like dengue, childhood respiratory viruses like rhinovirus, para-influenza virus, adenovirus, respiratory syncytial virus. Similarly, varicella, roseola infection, iridium infectious, rubella, scarlet fever, toxic shock syndrome are also the important differentials. Moreover, infectious mononucleosis and the exanthematous drug eruptions and even the multisystem inflammatory syndrome in the children from the SARS-CoV virus infection are also the possible differentials. Diagnosis is mostly clinical, and diagnosis is made based on the symptoms like cough, coryza, conjunctivitis, coplic spots, and the maculopapular rash that starts on the face. So clinical diagnosis is very important, and this clinical diagnosis is supported by the laboratory confirmation. And one of the most commonly used tests for the laboratory confirmation is the measles IgM antibodies. This test has the sensitivity of 83 to 89% and specificity of the 95 to 99%. Similarly, measles specific IgG titers can be done. Moreover, nowadays this PCR test is available, which can detect the RNA of the measles virus in the infected tissues, including the blood, urine, oral fluid, or nasopharyngeal specimen. In cases of the SSPE, antibody titer is very high in the CSF and the serum. That also helps in the diagnosis. There is no definitive treatment for the measles, so the treatment is mostly supportive. Patients should be treated with fluids for the dehydration, and the nutritional deficiencies should be treated. Basically, the vitamin A deficiency needs to be treated. And the early detection of the secondary bacterial infection and treatment with the antibiotics is very important. Other than that, isolation of the patient with the precaution to prevent the airborne transmission is also very important. Vitamin A supplementation has a very important role in the management of the measles because it prevents the eye damage, blindness, and it also reduces the number of the measles-related deaths because it plays an important role in promoting the epithelial cell turnover, particularly in the respiratory tract and the intestinal tract. So all the patients with the measles should be supplemented with 2 doses of vitamin A 24 hours apart, and the dose is based on the age of the patient. So for the children 12 months of age or older, 200,000 international unit is the recommended dose. Similarly, for the infant from 6 to 11 months, the dose is 100,000 international unit, and for the infants younger than 6 months, the dose is 50,000 international units. Antivirals like ribavirin has some role, but they are only used in certain cases. Steroids can be used for treating the measles-related pneumonia. Measles can cause various complications, among which pneumonia is one of the most severe complications, and it is responsible for the most of the measles-associated death. Similarly, other complications include encephalitis, severe diarrhea and dehydration, ear infections, sometimes blindness, and the secondary bacterial infections are very common. Moreover, it can cause myocarditis, febrile seizures, and even severe pneumomediastinum. There are some rare but serious neurological complications which include the acute disseminated encephalomyelitis, measles inclusion body encephalitis, and subacute sclerosing panencephalitis. So who are at risk of complication? Children younger than age of 5, adults over the age of 30, patients with malnutrition, vitamin A deficiency, and those who are immunocompromised are at more risk of developing the complications of measles. So for the prevention, vaccination is the best way to prevent the disease. Measles vaccine was introduced in 1963. It's a very safe, effective, and the inexpensive vaccine. It's given alone or in combination with other vaccines like mumps, rubella, or varicella. and it can also be used in the emergencies to stop the outbreak from spreading. Measles vaccine is the live attenuated viral vaccine. So the virus present in the vaccine replicates within the host to produce the long-lasting immunity. The vaccines are available in the various forms, like they're available as the monocomponent vaccine with measles only. They're combined with the mumps, rubella, or varicella as the MMR vaccine, and in some countries it's available as MMR vaccine. The timing is different according to the WHO and CDC. WHO recommends 2 doses. First dose to be given at 9 months, where measles is common, and at 12 to 15 months in the other countries, followed by the second dose later in the childhood, usually in the 15 to 18 months. Whereas CDC in the United States recommends the first dose at around 12 to 15 months and second dose at the age of 4 to 6 years. So the acquired immunity following the vaccination and the viral infection is usually lifelong. So for the post-exposure prophylaxis, we can either use the measles vaccine or the human immunoglobulin. So measles vaccine is given within 72 hours after the measles exposure, and human immunoglobulin can be given up to 6 days after exposure. So measles vaccine should be considered for all the exposed persons who do not have contraindications and who have not been vaccinated or have received only 1 dose of the vaccine. Similarly, immunoglobulin is particularly critical for the patients who are at risk of developing severe disease, like infants younger than 12 months of age, pregnant women without evidence of measles immunity, and severely immunocompromised patients. If a patient has received the human immunoglobulin, they subsequently need to receive the MMR vaccine, but the vaccines should not be administered earlier than 6 months after the intramuscular immunoglobulin or 8 months after the intravenous immunoglobulin. Prognosis is usually good. Between 1 to 3 children per 1,000 infected children die from the pneumonia or the neurological complications of the measles. So these are the references which we have used for making our video. Thank you so much for watching. Please subscribe to our channel for more videos.